Hi, everybody. And the topic of my talk is the management of epilepsy in women of reproductive age. Okay, so there's no conflicts of interest. And one thing that you guys may be wondering, since most of the people here are not neurologists, is how could this topic possibly relate to you? And the truth of the matter is that I'm sincerely hoping that epilepsy would actually serve as a prototype for any chronic illness that you may be particularly interested in that requires for a female to be on medication throughout pregnancy. And along with epilepsy, there is a slew of chronic illnesses where one has to keep their patients on medications, whatever they may be, for the sake of the mother. And obviously, there is this continuous dilemma. On one hand, you want to be the best provider possible for your female patients, on one hand. On the other hand, you also have to consider the future offspring and to try and give that future offspring hopefully a treatment that's going to be less problematic and would less likely cause major malformations. So the dilemma is where to find the balance of giving a medication that's going to help mom and not going to hinder the development of the newborn. So I'm going to share my world of epilepsy and several basic principles of myself, and I would say most of my colleagues in the field follow to try and navigate through this and try and find in our field the best balance. Okay. So we came up with 5 basic principles for choosing an appropriate anti-seizure medication, or ASM, for a woman with epilepsy in the reproductive age group. We'll discuss the available results from the 4 main anti-seizure medication registries. And we're also going to discuss how a change in the body physiology during pregnancy affects anti-seizure medication levels and management. Okay. So principle number 1 is to really know who is the enemy, right? Because once we figure out what type of epilepsy the patient has, then we can formulate the best treatment approach. And this is a relatively busy slide, I would say, but the key message here is there are really 2 types of epilepsies. One is this focal onset epilepsies, and you have focal onset seizures, and these generalized epilepsies. With focal onset seizures, basically what we are dealing with is very specific areas in the brain that cause seizures. With generalized seizure disorders, the conventional thinking is that you actually have a bihemispheric involvement of discharges that are occurring at the same time. And not surprisingly, because the pathophysiology is considered to be different, when it comes to medications, there could also be a difference, okay? So in patients who have focal seizures, there is several medications, and actually every year there's more and more of them, that would really work for focal onset seizures. But if you give those medications to patients with generalized seizures, it's quite possible that these seizures can get worse. So you really need to restrict those medications for focal seizures, okay? And then there are these generalized onset seizure disorders. And there are a few specific seizure medications, such as ethosuximide, that should really be restricted to certain types of generalized seizures. Then there is this list of what we call broad spectrum seizure medications. And those medications can really work for everything, okay? They can work for focal seizures, and they can also work for generalized onset seizures. So thankfully, in 2021, no matter what we are dealing with, if it's focal or generalized seizure disorder, thankfully, we have at least several seizure medications to choose from. And so how do we decide what's the best medication to give a woman in the reproductive age group? And that's where we go to the following principles, okay? So principle number 2 says we should look for an anti-seizure medication that has the least amount of birth defects based on the pregnancy registries that I will mention. Principle number 3 says we should look for an anti-seizure medication that should have the lowest possible effective dosages, and we'll talk about that as well. And we should also aim for the least amount of anti-seizure medications to give our patients, and I'll explain why that is important in the subsequent slides. The last principle, principle number 5, says that we should choose the best anti-seizure medication regimen as soon as possible if a woman has reached her reproductive years. And the reason for that, actually, I should also say that even if a woman expresses no desire to become pregnant, if there is a reproductive potential in her future, I can tell you that myself and most of my colleagues would really try as soon as possible as we adopt that patient to our clinic to try and find the best seizure medication for her type of epilepsy that would also be good, relatively speaking good, in the event that she becomes pregnant. And so medications such as valproic acid, we typically try, even though it's an effective medication, we typically try to replace it if the patient is on that medication because it is really known to have major tetragenic potentials. Okay. One thing that actually a lot of even physicians don't necessarily realize is that the neural tube actually forms in the first 4 weeks of gestation. So by the time the patient actually realizes that that she doesn't have her period and that she's possibly pregnant, that neural tube actually has already formed. And medications such as valproic acid actually are quite known to affect the neural tube for the worse. And unfortunately, we also know the statistics, at least the last statistics that we have from the CDC, which is from 2011. And at that point, it was actually reported that 45% of pregnancies in this country are actually unplanned. And in teenagers, it's up to 75% of pregnancies are actually not planned. And I can tell you, after doing this for a while, is that, I've had quite a few patients who over the years said, "Doc, trust me, I'm not going to get pregnant." And indeed, they did become pregnant. So for all those reasons, we try to be proactive and look for the best medications when it comes to, in the event that a patient becomes pregnant, that would not hinder the fetus too much. Okay. Another question that I've been asked quite a few times over the years is, "Hey, doc, shouldn't I just come off the anti-seizure medication if I get pregnant?" And yes, certain things like the neural tube have already formed, but there's other organs that are still in development, and maybe she should come off anti-seizure medications. Except what we know is that she should not. With most patients who have epilepsy, unless they have what we call focal aware seizures, and that's the only thing they have in their history where they're always aware of their seizures, unless they are in that category, truly they should not come off seizure medications. And that's particularly true if the patient has a history of generalized tonic-clonic seizures. And the big concern with generalized tonic-clonic seizures is in the midst of a convulsion, there is not enough oxygen for the fetus very often, and that asphyxia can actually cause permanent anoxic brain injury in the fetus. It can also cause trauma to the mother, to the fetus, and potentially even fetal demise. And for that reason, no matter how problematic some seizure medications can be, particularly if a person has convulsions, we definitely don't want to take them off seizure medications during pregnancy. The other question is, how do we know which anti-seizure medication has the least teratogenic effects? And the answer for that is we look at the pregnancy registries, which I will talk about. However, before we examine the data from these registries, we really need to define what is considered to be a teratogenic side effect. So all the registries, they really divide the teratogenic side effects into two major categories, right? And those are major and minor malformations. But thus far, they're really only reporting major malformations. And by major, the definition for that is it's really a structural anomaly with surgical, medical, or cosmetic importance, such as a cleft lip or palate, malformed limbs, cardiac or vascular anomalies, or neural tube defects, for example. When it comes to minor malformations, these basically, good examples for that is wide set eyes, short upper lip, slight difference in the shape of the fingers or nails. So truly defects that do not cause any serious anomalies. And over the years, we've had more and more registries that are coming up, and God knows we really welcome all of them. But the four registries that we follow the most, I should say, in the field, and these are the ones that we, in all the annual meetings, we hear about the outcomes from these registries. Those four are the North American Pregnancy Registry, and it's really a combination of patient registering from Canada and the United States. There is also the United Kingdom and the Ireland Pregnancy Registry, and patients from those regions actually registered to that registry. There is also the Europe registry, and it started as a European registry, but at this point, it's truly an international registry with over 45 countries from all over the world. And there's also the Australian Pregnancy Registry, and that's the smallest registry, but I have to say over the years, that registry actually has really helped quite a bit with providing us some significant data. The methodology between these registries is actually different, okay? One difference is the follow-up period. You have a follow-up period of 5 days when it comes to the North American Pregnancy Registry. The UK and Ireland follows the babies up to 3 months, and then you have the Europe and the Australian registry following these babies up to a full year. The other thing is who's reporting to the registries. And here too, there are differences. In some registries, it's the patient who is reporting. In some registries, it's the healthcare provider or both. And that potentially could cause some biases. Also, the numbers of patients that are being enrolled actually is quite different. You have the Europe registry with well over 20,000 patients versus the Australian registry with a couple of thousand patients, okay? And also, who are the patients who are taking the seizure medications? That too is actually different. You have the UK and North Ireland registry where they would only restrict patients who have epilepsy on seizure medications. These are the only patients that can actually enroll in that registry, versus the other registries, they would accept any patients who are on seizure medications, even if it's not for epilepsy, such as migraines or for neuropathy, for instance. Okay. But the interesting part is that despite the fact that the methodology is actually different, the trending of what is considered to be a safer anti-seizure medication versus less safe anti-seizure medication is actually rather similar between these registries, which is good news. So this is actually a slide that was presented in December 2019 in the American Epilepsy Society annual meeting. And it was presented actually by one of the Europe representatives. And it was a summary slide of 3 registries: the Europe, North American AED Pregnancy Registry, and the UK and Ireland Pregnancy Registries. And as you can see, the safest seizure medications that were considered to be the safest among all these 3 registries is levetiracetam, lamotrigine, and oxcarbazepine. And the worst offender, according to all these 3 registries, was actually valproic. And all of them found out to have the highest chance of major malformations, and phenobarbital was the second worst. Okay, so the story of what is the safe anti-seizure medication and what is not a safe anti-seizure medication really does not stop with just the last slide. The dosage also matters. And this is also a great slide that was presented by the Europe registry. And it's interesting because we keep saying valproic acid is, it's so terrible when it comes to pregnancy. But it's really, even with valproic acid, it really depends on the dosage. So at dosages of less than 650 milligrams total, and we have some patients who actually, you can treat them very well with those kind of dosages, the chance of a major malformation is actually less than 5%. But then when you move up to dosages beyond 1450 milligrams, that's when you start reaching the teens when it comes to major malformations. And the news that it's really all about the dosage actually has been shared by other registries as well. Okay. So the question, that the type of anti-seizure medication we prescribed changed over time since the start of the registry. So we have all this information. Are physicians across the globe, are they listening? Are they changing mode of practice? And thankfully, the answer is yes. Okay, so this is actually came from the North American Pregnancy Registry. And as you can see, lamotrigine and levetiracetam are now becoming the most popular seizure medications that are being prescribed. And the last data I was able to find for the Australian registry is up to 2012. But even at that time, you can already see that lamotrigine and levetiracetam actually are the most prescribed anti-seizure medications. And sure enough, also with the Europe Pregnancy Registry, as you can see from the orange and the blue, levetiracetam and lamotrigine are the most prescribed medication in the 45 countries that they are following. This is great news. We are definitely changing the way we practice. Great. But are we making a difference in birth outcomes because we've changed practice? And thankfully, the answer is yes. Now, we are all eagerly awaiting for more recent results. The last results we have is from a publication in 2019 from the Europe registry. And that really reflects a time span from 2000 to 2013. But even in that time span, if you're looking at the data from 2000 to 2005, looking at the whole registry and not specific, no specific anti-seizure medication, the chance of a major malformation was 6% for infants that were exposed to monotherapy and 8.3% for infants that were exposed to polytherapy, and particularly I can say for infants that were exposed to valproic acid in the midst of their polytherapy. And by 2010 to 2013, we are already seeing a significant reduction in the chances of major malformations with monotherapy and polytherapy. We're going from 6 to 4.4%. and 8.3 to 6.1%. And if we're thinking about it, we are really, by changing the way we practice, we actually really improved significantly outcomes for hundreds of kids around the globe. So it is rewarding that we are, that we have all that information and that we are acting on it. Okay. The next thing is actually, so yes, we have to worry about, looking for the safest anti-seizure medications, but as physicians, we also have to worry about drug levels. When it comes to epilepsy, we typically, well, ideally, we should know what the levels are that make our patients seizure-free. And then the goal is to follow that therapeutic level throughout pregnancy. But with pregnancy, things change. And seizure medications get eliminated either through the kidneys or through the liver. And some seizure medications go entirely through the kidney. And the kidney filters about 40 to 50% faster during pregnancy. So we actually have to hold on tight and adjust those levels so our patients would not seize. When it comes to the liver, it's really which enzymatic system the seizure medication is going through, okay? So and there's two major enzymatic systems. One is the cytochrome P450 enzymatic system, and the other one is the glucuronic enzymatic system. So when it comes to the cytochrome P450 enzymatic system, thankfully, the variations, the clearance is not that crazy. It's, there are variations between, the levels during pregnancy versus before pregnancy, but it's not too crazy. It's the glucuronic enzymatic system that really keeps us on our toes, where we can see very significant increase in metabolism, and we constantly have to change, actually typically have to increase the seizure medication to adjust to the pre-pregnancy therapeutic levels. And the biggest troublemaker is actually lamotrigine. So we really like lamotrigine because of the safety profile, but that medication is most susceptible for increased metabolism during pregnancy. And with all the seizure medications, typically the recommendation is to follow levels on a monthly basis. But I can tell you, sometimes with lamotrigine, we have to check levels even more than once a month, sometimes even once in 2 weeks, if a person is deemed to be a rapid metabolizer. And similar to other glucuronic, similar to other medication that go through the glucuronic system, when it comes to lamotrigine, even in the first trimester, we see an increase in metabolism, and it becomes even more robust by second and third trimester. And usually after 3 weeks post-pregnancy, the dosages actually, the levels actually are similar to the pre-pregnancy levels. But even here with lamotrigine, the story is not full. In the majority of patients, they have what we call the wild type glucuronic enzyme. And if the patient has the wild type, and that wild type actually binds to estrogen, there is a very marked increase in metabolism in the order of up to 219% increase. But there's also a subset that does not have the wild type of the glucuronic enzyme. It's about 21%. In that patient population, it's about 21% increase in the metabolism of lamotrigine. But typically, we have no idea what we are dealing with, so we follow these patients very closely, and it ultimately start getting a sense as to where that patient fits. The other troublemaker, and also one of the two most popular seizure medications that are being prescribed, is levetiracetam. And it's cleared through the kidney, and the glomerular filtration rate is increased by 40 to 50% in pregnancy. So here you can see even by first trimester, there is a significant increase in the clearance of levetiracetam, actually even more than 50%, and then it kind of comes close to the 50% range, extra 50% range of increase in clearance. The other two medications that go through the glucuronic system are oxcarbamazepine and topiramate. They're listed here in gray. And even here, you can see that there is increased metabolism by second and third trimester, although it's not as robust, thankfully, as it is with lamotrigine. And the other medications listed here actually go through the cytochrome P450 system. There you can see that there isn't much of a variation in the levels from months to months. So what have we learned from all of this? So the consensus from the results we have thus far is that by taking any anti-seizure medication, there is a likely increased chance of developing major birth defects. Valproic acid and phenobarbital were found to have the highest percentage of major malformations. If a patient has to be on polytherapy, we should aim for one that does not include valproic acid, if possible. And we should always aim for the lowest possible dosage. And a very important point of wisdom is remember to tell the patients that pregnancy is not a contraindication for women with epilepsy. Many years ago, a lot of physicians were telling their patient that it is, and that was a travesty. Well over 90% of women taking anti-seizure medications, looking at the group as an aggregate and not any individual anti-seizure medications, will have an infant who will be born without major birth defects, i.e. they will have a good outcome. Thank you. Actually, if anybody has any questions.
Actually, I have two short questions. Do you think that in the face of this relatively high safety, isn't it a good time to start clinical trials in women who receive ASM, because they receive ASM anyway, just to try and pin down which ASMs are better in a clinical trial setting where you have control over randomization, you know that you're representing the whole population, and whether you think it might be wise to include longer follow-up and look at cognitive outcomes beyond genetic malformations?
Yes, so yes. And I know we are a little bit out of time here, I see, but basically what I will say is, yes, we actually do have data, thankfully, of cognitive outcomes. We have been following these kids. There is two major, I would call them registries, and more studies really, the NEED and MONEED studies looking at cognitive outcomes. Unfortunately, just because of the length of the talk, I couldn't dwell into them. And the major news, and perhaps not too surprisingly, is the biggest offender when it comes to cognitive issues and reduced IQ and increased autism actually is valproic acid. The other ones, the other seizure medications are not as problematic. It's unfortunate because I like valproic acid. It's a medication, when I teach pharmacology, it's a medication that works in so many ways and it's very effective. But unfortunately, it's also a big contributor for cognitive issues and of course, major malformations.